Good evening, everyone. On behalf of the IIP Digital team, I, Dr. Manisha Tarpalikar, welcome you all for today's session. To celebrate World Physiotherapy Day, the IIPWC Kamrup branch, Assam, has organized today's session. The topic is prevention and management of osteoarthritis. Our speaker is Dr. Pinky Dutta, Associate Professor in Grand City University. The moderator for today's session is Dr. Urvashi Bhattacharya. I request all the participants to subscribe to the IIP India YouTube channel to receive regular updates and to view all the webinars. If the participants have any questions, they are requested to kindly write them in the chat box. These would be answered at the end of the session. I now request Dr. Urvashi to kindly take over. Thank you.
Thank you so much, Dr. Manisha. Good evening, everyone. A very warm greetings to one and all. I'm extremely delighted to welcome our speaker for the day, Dr. Pinky Dutta, all the panelists and participants of our today's webinar on prevention and management of osteoarthritis. Before handing over the session to our orator, I would like to take the privilege to introduce her. Dr. Pinky Dutta has a master's degree in physiotherapy in orthopedics and sports and is currently pursuing her PhD. She is presently working as an associate professor in Garden City University, Bangalore. Ma'am has around 13 years of experience in both academics and clinical. She has various publications in national and international journals, along with published book chapters and patents. She has also been awarded with the Best Woman Entrepreneur and Best Paper Award, to name a few. I want to thank ma'am for taking the time out to share her knowledge with us. Here, I would also like to ask the participants to kindly write down their questions in the chat box. So now, without further ado, I would like to hand over the session to ma'am. Ma'am, please.
Yeah, thank you, IIP India and Dr. Urvashi for inviting me as a guest to deliver this guest lecture on occasion of World Physiotherapy Day. So you have already, Dr. Urvashi has given a brief introduction about me. So I am Dr. Pinky and I work as an associate professor at Garden City University, Bangalore. So let me share you the screen. Dr. Urvashi, is the screen visible to everyone?
Yeah. Okay.
It has come into slide share, right?
Yeah.
Can I start, right? You can go ahead. Yeah. So all of you know, with the theme of this today, this year's World Physiotherapy Day is on arthritis. And I have just chosen a topic on osteoarthritis. So I will be covering about a little bit about the definitions, little bit about the causes, the pathomechanics, the prevention, and also the management. And I do understand we have a time limit, so I may not be going into much depth into it, but I'll try to touch up all the categories of arthritis, whatever the important points in it. So when we hear the word arthritis, or especially when we hear osteoarthritis, what comes in our mind? That means the old people, the elderly people are more affected, right? Yeah, that is a common, like, it comes to our mind whenever we hear the term osteoarthritis. So as said, OA, the short form of osteoarthritis, we call it as a OA. And I have defined it kind of OA as O means old age, A is arthritis. So it is an arthritis which you see commonly in the old age. But it is not necessary that only the old age people will be affected. It can affect any kind of a age generation. But the old age people are more commonly affected. So coming to an introduction, so OA is the most common condition treated by the physiotherapist. So whenever we see patient in clinic, if you see among 10 patients, definitely and around 3 to 4 patients we come across osteoarthritis. It is the most common form of arthritis worldwide. It can occur in any synovial joint. The most commonest sites being the knees, hip, and small hand joints. The consequences of osteoarthritis include pain, reduced function, and restriction in daily activities. Am I audible? Because I got a notification that internet is unstable. I hope my slides are visible and I'm audible also, right, Dr. Urvashi?
Your slide is an introduction slide is only there.
it showing the same to you all?
Your slide is not visible now.
Now it is visible?
No.
Ma'am, you need to screen share again. It has stopped. So please screen share again. It's not
Okay.
visible.
It is visible? Is it visible?
No, ma'am.
No, it's not visible till now.
It's showing me stop sharing this coming, but I have shared it. And it shows I have a good internet. Let me
Ma'am,
again
stop
share it.
again. Stop sharing and reshare it again. Stop and then
Okay.
again share the screen again.
Now also not visible.
No,
No.
ma'am.
Okay, stop sharing. Now is it visible, madam?
No, ma'am, we can't see your.
I don't know. It's me here. It is showing as visible, but I'm audible to you, right?
Yes,
Only
you're
I'm not visible. Let me stop the video and see maybe the internet. Now,
No.
is it visible?
No, ma'am.
I don't know how it happened suddenly. Okay. Screen sharing has failed to start. Please try again.
Yeah, so please share again, ma'am.
I'm doing it. Again, the same code is coming. Why it is coming also to me?
Dr. Pinky, can you share your? It has started. Yeah.
Now it is visible.
Yes, ma'am. Yes. Yes.
Yeah.
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 Yes.
Yeah, sorry for the inconvenience.
No.
Let me go to the definition. So let me come up with a definition that was set by the famous researcher named Carol David in the year 1999. He said that definition of osteoarthritis varies, but considered to be a chronic degenerative and progressive condition affecting the synovial joint. There was another definition given by John Ebenezer in the year 2003, where he said that it is a degenerative, non-inflammatory joint disease characterized by destruction of the articular cartilage and formation of new bone at the joint surface and margins. So similarly, there were different researchers who had done a lot of research on osteoarthritis, and they have quoted different definitions. So we come to know that osteoarthritis is one of the most common form of arthritis, degenerative arthritis, that affects any kind of a population, and especially the older generations. So coming to the classification, the osteoarthritis can be classified basically into three categories. According to the number of joints, we call it as a monoarticular or the polyarticular. Where monoarticular, only one joint is involved, and in polyarticular, there can be n number, multiple joints are been involved. Then according to the type of osteoarthritis involved, that it can be an inflammatory osteoarthritis or it could be a generalized osteoarthritis. There are also other classifications where osteoarthritis is been classified, subclassified as primary idiopathic osteoarthritis or secondary osteoarthritis. So we got to know about three different types of classification. The first is only one single joint involved, that is monoarticular, polyarticular, multiple joints. We have inflammatory, generalized, then we have primary and secondary osteoarthritis. Coming to the pathology of it, osteoarthritis is a multifactorial, metabolically active process which begins in the middle age, that is most commonly after the age of 40. It was thought to be only degenerative, but it have repetitive features. The activity and behavior of chondrocytes provides the key to progressive nature of joint degeneration. Then coming to the pathomechanics, increased in water content in the articular cartilage, changes in quality of collagen fibers, which increased in the diameter and disrupt collagen bundle. At molecular level, we have loss of proteoglycans in the cartilage and severity of lesions appear to be proportional. So there is repetitive weight bearing on such cartilage leading to wear and tear. So to come into a brief, if there is an excessive weight, if there is an excessive weight bearing to your joints, there is a chance that there will be a wear and tear to your cartilage. There is a chance that the collagen fibers will also disrupt. Further continuation to the pathomechanics, there is further rubbing, that is rubbing of the subchondral bone, which becomes hard and glossy. So when the joint spaces decreases, the bone starts rubbing, the friction within the joint space happens. That is called as further rubbing of the subchondral bone. The bone at the margins of the joint hypertrophies to form a rim of projecting spurs known as osteophytes. So we are all very familiar with the term osteophytes, right? Osteophytes are small bone regenerations. So this osteophytes forms at those joint spaces where there is maximum amount of erosion to the bone. The loose flakes of cartilage inside synovial inflammation and thickening of the capsules. Because of the loose flakes of the cartilage and because of the thickening of the capsule, we always, in the clinical features, we always see stiffness of the joint, we always see tightness of the muscle, and in later cases, we also see deformities of the joint. The common tissues that are involved in osteoarthritis are your cartilage, bone, capsule, synovium, muscle, ligaments, bursae, and the vessels. In the cartilage, we see focal softening on the loss of cartilage. In the bone, we see osteophytes or sclerosis development. In the capsules, we see thickening of the capsules. The synovium also we see thickening and also inflammation of the synovium. Then in the muscles, in later cases of osteoarthritis, we see there is atrophy of the muscles. Because of atrophy, again, we can see weakness to the muscles. There is degeneration of the ligaments. There can be a chance of bursitis to the bursae and also a chance of avascular necrosis or venous hypertension. So I think all of us are quite aware about the clinical features. So the common clinical features in osteoarthritis, what we see are pain, muscle spasm, stiffness, inflammation, loss of range of motion, the capsular pattern, then muscular inhibition and atrophy, joint instability, crepitus, deformities, and reduced function. I don't think so I need to explain about the clinical features. I think all of you know it very well that a patient who has osteoarthritis always presents with you with pain. There's muscles around, in and around the knee joint or in and around the joint involved has spasm. And as spasm is also a protective mechanism. Then we see stiffness to the joint. We see inflammation, the signs of inflammation. That is what we see: swelling, we see redness, we see the temperature of the inner surrounding area increases. There is loss of range of motion. The loss of range of motion is mainly because of there is stiffness to the joint or because the bones are weak, or it could be because of an osteophyte formation which is restricting the range of motion. The muscular inhibition and atrophy of the muscle, joint instability. Yes, obviously if the bones or the joint has become weak, there is instability to the joint. We also hear crepitus. Crepitus is that rubbing of the bone, rubbing of the subchondral bone. In later cases, we see deformity. Normally we see a patient with osteoarthritis come up with a flexion deformity, come up with a little abduction deformity, and also which again in later life reduces a person impaired scheme to perform his activities of daily living. Coming to the radiographic findings, the common X-ray changes what we see are a loss of joint space. Yes, the joint space, if I give you an example of the knee joint, the joint space between the femur, between the tibia, the joint space between the tibia and the fibula, the joint space decreases. There is sclerosis, that is erosion of the bone. There is altered bone and shape. Now, yes, if there is a sclerosis of the bone, if there is a porosis of the bone, we do not have an even shape of the bone. We do not have an even shape of the lower end of femur. We do not have an even shape of the upper end of tibia. So there can be the shape of the bone can be altered, and also formation of osteophytes. Now, I would just like to add upon one point on osteophytes. See, osteophytes initially this osteophytes form because the bone becomes weak and they cannot take the weight. So this osteophyte forms so that they can share the weight. But as time passes through, the osteophytes grows in size. Now, once this osteophyte grows in size, there is a high chance that this osteophytes might impinge any of the soft tissue. They can impinge the ligament, menisci, they can impinge your bursae, they can impinge the muscles, and even at times it can impinge the vessels, which might cause up into any kind of embolus formations. I think audience, I think I'm going a little fast because we had a technical issue in which I have lost some time also. Now, let me tell you about a grading of Kellgren and Lawrence grading system of osteoarthritis. So it has been graded into 4 different grades. Grade 0 is normal. Grade 1 is doubtful narrowing of joint spaces. Grade 2 is definite osteophyte. That is, there might be a possibility of narrowing of the joint space too. Grade 3 is moderate multiple osteophytes, definite narrowing, some sclerosis, possible deformity of the bone ends. Then grade 4 is large osteophytes, marked narrowing, severe sclerosis, and definite deformity of bone ends. So as we see the grade from grade 0 to normal, grade 0 is termed as the normal, a person without arthritis. From grade 1 to 4, you can see the osteoarthritis, the arthritis symptoms are been increasing. That means the sclerosis or the porosis that has happened to the bone and the joint has been again aggravated. Now, this is a picture of an X-ray of a recent patient that I had seen. You can see the irregularity of the bone. You can see the endings of the femur here, right? You do not have a very definite ending. It is little irregular. It is a little hazy and little opaque. Now, coming about a reduced function, all the clinical features described above can result in functional difficulty. So functional difficulty, I mean to say any kind of activities of daily living, like walking for a minimum amount of distance, climbing a flight of stairs, so getting out of a chair from sitting to standing position, then walking in and around, doing your normal daily activities, walking in the kitchen where you need to stand for more than 15 minutes. So this is a flow chart where we say it is how osteoarthritis, the signs, symptoms, and the clinical features are interrelated. You can see inflammation, you can see effusion. Because of effusion, we got muscle inhibition. Because of muscle inhibition, reduced function, instability, again leading to inflammation. Now, if you see from inflammation, we have symptoms of pain, loss of range of motion, muscle atrophy, again leading to reduction of your daily activities, reduction of function. Coming to malalignment, there are some causes where a person get osteoarthritis because of malalignment. If there could be a deformity from the birth itself, where the lower limbs or the joints which are wherever it is affected are not being aligned properly, there is a malalignment. So the angles of the joints are not proper. For example, if the Q angle is malaligned, there is a high chance that the weight bearing capacity of the joint will be altered, because of which also there are consequences of osteoarthritis to happen. So coming about ground reaction forces, in neutrally aligned knee, it passes slightly medial to the knee joint. The ground reaction force passes slightly medial to the knee joint. In varus knee, it is more medial, and in valgus knee, it is more lateral to the knee joint. So these are few of the red flags in clinical, laboratory, and radiological. I think all of you know what do you mean by red flags, right? So if a person have absolute red flag, we cannot proceed for our assessment or our treatment. The pattern of joint involvement, primary osteoarthritis can be further subdivided into localized or general, involving 3 or more set of joints. The more common joints involved in osteoarthritis, here you can see in this picture, the pictures where I have highlighted in little dark gray are the common joints which are being commonly affected in osteoarthritis. So we can see the knee joint, hip joint. We can also see the distal joints of your hand. Coming to the management part of osteoarthritis. So I have divided the management into three broad categories: the pharmacological category, the conservative, and the surgical category. After this, we will be discussing about the physiotherapy management. So coming to the pharmacological category, we do not deal much into the pharmacological category of management, but the common drugs that have been used in the management of osteoarthritis are acetaminophen, the NSAIDs, the non-selective NSAIDs, the COX-2 selectives, tramadol, opioids, joint injections, the steroid injections, the supplements, glucosamine or chondroitin sulfate, and many more other type of drugs. So there is a saying which was said by Edward Stanley: those who think they do not have time for bodily exercise will sooner or later have to find time for illness. So this is something which I would say is the mantra for the prevention of osteoarthritis. So start exercising today, take care of your health, manage your weight, so that later you do not have to fall under the category of arthritis. So I repeat the phrase again: those who think they have no time for bodily exercise will sooner or later have to find time for illnesses such as arthritis. So the aims of the physical therapy. So here we come mainly about the what are the main aims we do, what are our goals in the treatment of osteoarthritis. First, we need to educate the patient. Secondly, we need to reduce pain, inflammation, and stiffness, eliminate aggravating factors, maintain or improvement of range of motion, to maintain or improvement of muscle strength, to restore muscle balance, to reduce stress on the involved joints, to retrain gait, to maintain or improve in functional independence, including participation in a vocational activity. So we have a huge list of goals. That means being a physiotherapist, you have a lot of responsibility to meet each of these goals. So to meet each of these goals doesn't happen in a flicker of seconds. So we require a timeline so that we can achieve each of our goal. So coming to I would like to be going to a little bit in detail. So I was a little rushing up in the first part. So coming to patient education. So patient education is a primary goal here. So if you need to educate the patient about arthritis, and you not need to educate the patient once they have developed arthritis, start educating the patient. Start educating the patients before. So as a physiotherapist, you can conduct some wellness camp where you can educate what happens if your weight is increased, what happens if you do not do exercise, what happens if you can do a repetitive activity for a prolonged period of time without taking rest. So a major objective of education is to improve patient knowledge in order to integrate him or her into the decision-making team. Content should include information concerning osteoarthritis, the pathophysiology, clinical presentation, how the disease is assessed, its natural course, and the indications and expected results of various treatment modalities. So you need to make awareness, create an awareness to the patient, create an awareness to the locality where you stay, that the importance of exercise, the importance of physiotherapy for the prevention of osteoarthritis. So the route of administration include discussions with health professionals, group discussions, or self-reviewed materials, example booklets or websites. In this here again, if it is a little bit of a rural area, you can take help of the ASHA workers, you can take help of the getting connected with the primary health centers. The next point is our exercise. The goal of exercise to prevent or delay disability. An exercise program should incorporate to lessen pain during activity, to increase or maintain joint range of motion, to strengthen muscle, to stabilize the joint, to improve aerobic capacity or level of conditioning. And exercise in osteoarthritis should be adopted according to the presence and the severity of pain. Now here, if the person is already, we have discussed about the grades, right? So if the person is already in a grade 3 form of osteoarthritis, so at that point, you cannot go for too much of a vigorous exercise because that can aggravate the condition. So according to in which level depends on the clinical features, depends on the tolerability of the patients, depends on the strength of the bone, depends on the bone mineral density, you have to plan your exercises. So exercise can be used both as a prevention and also as a therapeutic later after you develop osteoarthritis. So in painful episodes, you can go with isometric exercise. You can go with non-weight bearing exercise. You can go with partial weight bearing exercise. So whenever the patient presents with pain, then better to go for isometric exercise. I think all of you are quite aware what is isometric exercise. Isometric exercise are those where there is no change in length of the muscle. So when we do isometric exercises, we do not put lot of, like a stretching effect. There is no stretching effect to the muscle, that we are lengthening the muscle or we are putting too much of effort to the muscle. So then next, after isometric, we can go for non-weight bearing, and non-weight bearing means open kinetic chain exercises. The open kinetic chain exercise are also those exercises where the weight bearing to the joint affected will be less, because as we said, the joint space is reduced. If we further give weight to the joints, it might further aggravate the condition. Next is your partial weight bearing exercise. So partial weight bearing exercise can be done in the form of an aquatic exercise. And believe me, in aquatic exercise for osteoarthritis, even at the most painful condition, even in grade 4 or grade 5, does wonders. Next is in painless, where you have less painful periods of arthritic pain. The exercise program may include progressive muscle performance exercises. So where we can include our strengthening exercises. Now, for example, if I take about the, just as an example of your knee joint. So the strengthening exercise that I'll be doing is strengthening of the muscles in and around my knee joint. That is strengthening my quadriceps group of muscles. That is my rectus femoris, semitendinosus, membranosus, then my vastus medialis, right? Then we need to strengthen the hamstring group of muscles. We need to strengthen even our lower back muscles, even our gluteal muscles, and also the adductors and abductors of the hip joint. So a possible role for quadriceps strengthening exercise in showing disease progression was first explored in the year 1999. So there was a first study done in 1999, where in that research study, they have found a very good results by strengthening quadriceps exercise. Now, one more thing to add on. See, if there is already formation of osteophytes, if there is already sclerosis or already porosis of the joint, we cannot reverse that. Right? We are doing exercises in order to strengthen the muscle in and around the joint. So if our muscles are strong, the joint which has been affected, so if the in and around the muscles, if they are strong, they will hold the joint, they will make the joint stable, because we cannot reverse the osteoporosis, right? So definitely they are, together with the physiotherapy, they are on medical managements, they are on calcium supplements, they are on vitamin D supplements, right? So strengthening exercises. Then this is again a quadriceps muscle strengthening continuation. So quadriceps strengthening exercise have consistently found significant reduction in pain and improvements in physical function. Stronger quadriceps muscle reduce the risk of developing radiographic knee OA. Quadriceps muscles play a large role in resisting the abduction movement. Women with a moderate to high isokinetic quadriceps strength had respectively a 55% to 64% reduced risk of developing hip or knee OA. So again, I also mentioned you already, I have mentioned about strengthening of the hamstring group. Then again, then strengthening of the hip abductors. Then again, if we have, because of the if we have weakness of the hip abductors, also there are possibilities, because of the weakness of hip abductor, you might develop arthritic changes. Because if your hip abductors are weak, there might be, the pelvis will not be at a level, there will be drop in the level of the pelvis. There will be, if the pelvis is not at a level, you will have your deviation of your center of mass, your COG, your LOG, right? Then this is also again continuation of the hip adductor muscle strengthening. Then let me go to the stretching exercise. So stretching exercises for the hip flexors, hamstrings, and the calf musculatures helps improving the range of motion, pain, and flexibility of knee osteoarthritis. Now, when we go for strengthening exercises, make sure you have to see, do a detailed assessment to check that in which grade of osteoarthritis the patient is in. His joint is in which grade? If it is in grade 1, 2, 3, 4, in which grade? Accordingly, you have to do the stretching. Because if you do not see about the, if you do not notice in the x-ray there is an osteophyte and you start strengthening the muscle, then there is a high chance that this osteophyte might prick the muscle, and it might cause an impingement. It might cause a mild tear to the muscle. So stretching could be done to the muscles in and around the joint affected. So here, whatever I have said about hip, hamstring, and calf muscles are taking an example that your osteoarthritis is of your knee joint. Then coming to the other flexibility. Now, when we go for this flexibility exercise, normally the stretching exercise, what should be our prescription? What should be the mode? What should be the frequency? The mode is gentle static stretching. I think all of you know there are different types of stretching. We have dynamic stretching, we have static stretching. So initially go with a static stretching. Frequency, minimum 2 to 3 days per week. Intensity, stretch to a position of mild tension or discomfort. Duration, hold the position for 10 to 30 seconds. Repetition, 3 to 4 repetition for each stretch. So this prescription, what I have mentioned here, is from few of the research articles that I have got, where they have, when after following this prescription, they have got a tremendous good result. Coming to gait retraining, gait patterns can influence loading at the knee joint, and thus changing them through gait retraining, which could slow the disease progression. Now, if you have a deformity in your gait cycle, if your gait pattern is been altered, for example, if very commonly we see flat foot, right? People who have flat foot, if you notice their gait pattern is slightly altered. So a person with a flat foot, what happens to him? The medial arch of his foot has been collapsed. So because of that, the weight bearing capacity is been altered. The amount of weight that needs to pass through the knee joint then to your foot is been altered. So in those cases, there is a chance that the knee is prone to be, the knee is stretched on bearing more amount of weight, which in later might, go for early degeneration. So also when we're doing the assessment of the patient, to definitely conduct a gait assessment. So if there is any alteration of the gait, you need to correct the gait pattern. Coming to aerobic exercises including cycling, swimming, walking has been found to be effective for relieving symptoms in osteoarthritis. So this I have said in relation to osteoarthritis of knee. But if you have arthritis of your distal joints of your hand, then exercises where you involve your small joints of your hand more than the others are more beneficial. Such exercises could also have benefit for longer term joint health by assisting with weight reduction. So what I mean here, as we said, if the weight is more, if a person is obese, there is more amount of weight the joint needs to bear. So by performing aerobic exercises, there is a possibility that your weight can come into control. But one more thing here, weight do not come into control without having a proper balanced diet. So the combination of dietary weight loss and exercise, including both aerobic and resistance components, was more effective in improving function and pain in people with knee osteoarthritis. Coming to appliances like orthosis or knee bracing, supports and appliances, braces, corrective devices may assist in relieving pain and improving function of affected joint. They are used to reduce vertical forces applied to the skeleton at the heel strike and realign unstable or structurally deficient joints with restoration of normal force distribution, improve proprioception, and improve stability and patient perception of instability. Now, when orthosis or any kind of an assistive device is mainly used in order to share the workload, in order to share the weight bearing capacity. So if a person who has mild amount of genu valgum, and if you use a brace which corrects it, then the knee will not have to bear more amount of weight. The ideal amount of weight the knee will be bearing in those cases. So orthosis or any kind of braces, usage of braces can also share the weight. Now, very commonly when we see knee osteoarthritis, we ask the patient to wear a kneecap, right? A knee brace, kneecap. So when they wear a kneecap, some amount of weight is being shared with the kneecap, right? But at times, what happens is the patient gets so used to the kneecap, that they do not go for doing the exercise to strengthen the quadriceps muscles, but they start wearing the kneecap because they find it comfortable. Coming to shock absorbing insoles. Viscoelastic materials used in footwear or in insoles augment body tissues, particularly the heel pad, in reducing the magnitude of the heel strike tension. With age, heel pad structure alters and results in a loss of shock absorbing capacity. So viscoelastic insoles can attenuate transient forces incurred during walking, running, stair climbing, and jumping activities. So if especially in the older age, if while assessment, just next time when you assess an osteoarthritis, just try to assess the heel of the patient. So we all have a cushioning effect at the heel of our foot. This cushioning effect is mainly for absorbing the shock. Like the most common structure in the human body, we say about the intervertebral disc, right? This intervertebral disc are the shock absorbers of your vertebral column. So this we have this the heel pads. Okay, the heel pads bear the acts as a shock absorber. But as the degeneration happens, as you proceed in your age, the heel pads decreases, the density of the heel pads decreases. So you can use an implant like an insoles, a viscoelastic material. Normally we get it of silicone materials also. So this kind of insole, if you use, it helps you to divide the weight. It helps you to distribute the shock of the body. Next is now, this was a brief about the exercise therapy protocols that we use, but we know we are, when we say about only strengthening, we say about stretching, it's not about one muscle. We need to go for doing all about the in and around the muscles of the joint that has been affected. Coming now for the pain relief, electrotherapy for pain. So this is the first treatment of choice. Whenever any osteoarthritis patient comes to us, the first thing what they comes and say us is, we are in pain, please try to reduce our pain. So we work on relieving the pain, then we start progressing to the exercises. So electrotherapy modalities, electrotherapeutic machines modalities are widely used in physiotherapy departments to decrease pain associated with osteoarthritis. So the popular treatment includes the usage of ultrasound, IFT, SWD, laser, and TENS. And now, and as because of we have a lot of new innovations, where many practitioners, physiotherapy practitioners, have got good results by using matrix rhythm therapy. They have got good results by using PEMF, pulse electromagnetic frequency, then also about shockwave therapy. But still, I would not like to mention about that, because all the new innovations are still under research. Okay, the proposed physiological effects of these modalities include deep heating, increased blood flow, reduced muscle spasm, promotion of inflammatory response, and pain relief. So all of our electrotherapy modalities have a common mode of effect. They are all work, they all work on decreasing pain. How? By causing in some of the modalities they cause a deep heating, in some they increases the blood flow, like equipments like IFT, laser, SWD. They do very good job in increasing the blood flow. They reduce the muscle spasm. So if your blood flow is increased, definitely your muscle spasm also will come down. And spasm is a protective mechanism. So whenever there is an injury to any part of the body, we get a spasm in the form of swelling, in the form of edema, right? So they, in all of this electrotherapy modality promotes, they do a promotion of the inflammatory responses and thus decrease the pain. So there are many laboratory-based studies that demonstrate the physiological effects of electrotherapy modalities that should theoretically produce therapeutic effects. Until clinical trials replicate laboratory findings, electrotherapy cannot be considered as an efficacious, cost-effective, evidence-based interventions for osteoarthritis. Now, why this is a very strong statement, I am saying it here. Electrotherapy cannot be considered as the most effective mode of treatment. Yes, we also said, I also mentioned before, the osteophyte, the sclerosis or the osteoporosis that has happened to the joint inside, we cannot reverse that. So how we are doing is, we are working on the neighboring structures, the muscles or the soft tissue structures, to strengthen them so that they provide a more stability to the joint. So the electrotherapy modalities, what we are using, they all work for pain relief. So when we use this, because of the increase in the blood flow, there is a washout of the endorphins and enkephalins, so our pain decreases. But if after your pain decreases, you need to continue with the exercises, because the damage that has been there, that damage is already there, right? So we cannot keep on using the electrotherapy 10 days or 15 days. right? So later we need, once the pain is under control, we need to continue with our exercises. However, it should be noted that patients generally like electrotherapy treatment, and considered placebo effects could be used to enhance other aspects of a treatment. Thermotherapy, the heat applied through various heated packs relieves pain. And we all know what is the physiology behind heat. The physiology behind heat, we have, they increases the blood circulation. As the blood circulation increases, it starts blocking of your pain gate mechanism, that is washes out the pain causing substances. It closes the pain gate, improves the local circulation, increase the collagen extensibility, reduce muscle spasm, and improve range of motion. Similarly, the cold therapy is applied through ice packs or ice bath, which may relieve pain via the pain gate mechanism, reducing peripheral nerve excitability and reduction in joint effusion and edema. Now, here is your decision making time, at which time you are going to use the thermotherapy and or which time you are going to use the cryotherapy. So if there is an inflammation to the joint, an active inflammation to the joint, you are definitely going to use cryotherapy only. And if you see there is no inflammation, you can go for the thermotherapy, any form of heating modalities in physiotherapy practice. Thermotherapy appears to be a simple, cost-effective means of assisting pain control, and therefore is an appropriate tool. But whenever for home exercise, or whenever the patient comes to you, they always are more prone to use thermotherapy. So at that point, you need to explain the differences between a cryo or a thermotherapy. Next coming is our ultrasound. Ultrasound is probably the most commonly used electrotherapy modality, especially for hip, knee, and vertebral osteoarthritis. It is claimed to alter cell functions, vascularity, collagen extensibility, resulting in a pain-free effect. A meta-analysis of ultrasound in musculoskeletal conditions concluded that it has no role in the relief of pain, but it has, what it does, it alters the vascularity, it alters the collagen extensibility. Because of the extensibility of the collagen, because it alters the cell function, it increases the vascularity. In turn, it will decrease the pain. Coming, I think this slide, I hope it is visible. It's slightly, I think it got, both together. So coming to about stimulation therapy like TENS. So TENS receives widespread use in many acute and chronic pain conditions. The main theoretical rationale for pain relief is that electrical stimulation of large diameter neural fibers closes the pain gate. Alternatively, counter-irritant stimulation may facilitate release of endogenous opioid substances. TENS can effect pain relief when used at a high frequency or strong burst mode for more than 4 weeks. So TENS gives a very good relief in decreasing pain when we use at a high frequency, and when we deliver a strong burst mode. When you use the strong burst mode, it gives a very good effect. But the effect of TENS you do not see very immediately. It takes a little time. But when you compare to IFT, effects of IFT, you see it very immediately. But TENS takes a little time, but it gives a very good effect when you use a burst mode and when it is used at a high frequency. Next, about IFT, physiological effects of this modality differ according to the level of stimulation and the type of nerve fibers stimulated. So when it is stimulation of motor nerves, it leads to muscle contraction. As a result, increases the circulation in the area. This is limited use in osteoarthritis, where active exercise is of proven benefit. Sensory nerve stimulation, facilitating opioid production and closes the pain gate. However, there is no evidence for its benefit in stimulating healing, and only limited evidence supporting analgesic effect. So there is nothing. So whenever this electrotherapy modalities are used, they do not directly, like how the effect of pharmacological agents, that they directly block the pain pathway. But all of our electrotherapy modalities, they work by increasing the blood circulation, increasing the formation of more collagen fibers, improving the function of our cells. Coming to SWD, shortwave diathermy have been used in variety of orthopedic and musculoskeletal conditions with varied success. Pulsed or continuous delivery results in tissue heating and subsequent increased circulation of the treated area. Cell membrane potentials may also be affected, although this theory remains contentious. So use of shortwave diathermy. Though shortwave diathermy was very popularly used before, but now there are circumstances or researches are been less in shortwave diathermy as of now, where people therapists are not much preferring the use of shortwave diathermy. Now coming to low level laser therapy, LLLT. LLLT has evolved as a therapeutic intervention for osteoarthritis over the last decade. Therapeutic doses are too low to induce thermal effects within the tissues, and the physiological benefits are thought to derive from photochemical reactions at cellular level, which produce an anti-inflammatory effect. So here, usage of laser when you use is induces thermal effects within the tissues, and the physiological benefits are thought to derive from the photochemical reaction. So whenever you use laser, there is a thermal effect and also there is a photochemical effects, which helps in decreasing the pain. Next, coming to the hydrotherapy. Hydrotherapy consists of heated pool, is popularly with patients and effective in relieving pain, improving joint range of motion, and patient function and quality of life. So due to demand and limited resources, treatments are normally of short duration with little possibility of follow-up treatments. So hydrotherapy is a very popular treatment in the Western countries, but if you see in our country, there are very less less setups where hydrotherapy are being used. But hydrotherapy gives a very good effect, even if it is a grade 5 of osteoarthritis. Also, hydrotherapy gives a very good effect. Using of walking aids, sticks and crutches are supplied to reduce the stress applied to weight-bearing joints and to improve patient stability during ambulation. Unfortunately, walking aids are not always popular with patients who perceive them as being for the elderly and infirm. Now, in osteoarthritis, as we said, it affects from the middle age, from the age of 40. So initially, when they have osteoarthritis, if they, during the prevention stage itself, together with the treatment, if they use any kind of a walking aid where the weight is being distributed with the walking aid, it will further prevent them from aggravating the condition. Now, manual therapy. Physiotherapists, osteopaths, and chiropractors use different type of manual therapy techniques to reduce joint pain and stiffness, and also increases the range of motion. Now, here, whenever we say about manual therapy, we do different grades of manual therapy. So, grade 1 and grade 2 are mainly done for the relief of pain. But if you are going for a manual therapy of grade 3, 4, that is mainly for increasing the range of motion. But going to manual therapy here, you have to be very careful because the bone is already been degenerated. There is already been osteoporosis. There might be presence of osteophytes also. So whenever you go for manual therapy, you have to be very careful about which grade to select. So manual therapy should not be the first treatment of choice. So the first treatment of choice should be with a electrotherapy modality for pain relief, then with the various exercises that we discussed. Then in later, as you see, the muscles have become quite strong. The patient is also on other supplements, and the bone density has also been increasing gradually. Then you can go for manual therapy practices. So in manual therapy, we go for joint mobilization. So various type of joint mobilization techniques like Maitland mobilization, Mulligan mobilization. We at times we go for Cyrex mobilization in also for improving the range of motion. Now coming to massage. Massage, I would not say as the first treatment of choice, but here massage helps a lot in decreasing pain, because through massage the blood circulation is being increased. It causes a decrease in spasm. So any kind of serious, any kind of a massage techniques, be it the deep friction massage, be it the effleurage or the kneading technique, helps in reducing pain. But again, massage, we have to be careful that we do not apply pressure to the joints, and it is purely done on the muscles. Then other techniques like taping of the joint. Now again, it depends on which joint is being affected. Accordingly, we need to do the taping, and the main principle behind taping is to share the weight, so that the tape can also bear some amount of weight which is been kept on the joint. So it is aim is to control the in the knee joint. We normally do taping of the patella because the main aim is to control the tracking of the patella and to minimize the contact stress. Once you apply the tape, it will definitely decrease the stress. The most common method is medial in patella. We use a medially directed taping to offload lateral compartment of the patellofemoral joint. Next, other physical recommendations for health is activity. Normal daily activities like walking, yard work, etc. Frequency, most days of the week. Intensity, moderate, 55 to 70% of age predicted. Then duration, accumulate at least 30 minutes of the activity. So once your pain is been under control, once you have learned the exercises, your stiffness has also reduced, then continue to have a healthy lifestyle by maintaining the exercises, by maintaining different types of physical fitness regimes. I think this is about fitness. It is a references. So with this, I would like to conclude. I think it was a very short session. Maybe next time we can do it in more detail. I had a little time constraint also, so I had a little rush up. But any questions, if anyone has you, I'm open to questions.
Thank you so much, ma'am, for the enriching session. We have a question here from Dr. Manoj Khakra. He has written that as you have already said that there is inflammation during osteoarthritis. So how good it is to use heating modalities in such conditions?
Yes. That's a very good question. Yes, we say the definition itself suggests osteoarthritis is a degenerative and inflammatory condition. Yeah. Now, what happens during the initial symptoms of osteoarthritis? You have inflammation. So when you assess and see, you feel the warmth of the in and around the joint. But once the patient is under treatment or the patient has decreased the weight, weight bearing, the patient has decreased those activities which was, causing the pain, then the inflammation comes under control. But whatever the degeneration that has already been happened, that is the osteoporosis has happened, that is still there. So at that point, we would say that the inflammation is under control, but the degeneration or the osteoporosis is there. So in those stages, we can definitely go for a heating modality, because by using heating modality, it will, increase the blood circulation and decrease the spasm. But if inflammation is present, we definitely cannot go for a heating modality. I hope this is clear.
Yeah, ma'am. There is one more question. Whether massage will increase the myocytic ossification in the patient?
Yeah. Now here, see, myositis ossification is a new growth in the muscle. Sometimes it happens at the muscle. Now, all cases of osteoarthritis will not have myositis ossificans, right? Myositis ossificans, if I would give a very classical example, you see myositis ossificans in fracture in and around the elbow. Whenever you have a fracture in and around the elbow, there might be myositis ossificans, and myositis ossificans develops not at just after the surgery, during the rehabilitation process. Now, a similar case in an osteoarthritis, if there is a myositis ossificans, and it will be visible in an X-ray. If myositis ossifications is visible in any of the investigation, we definitely cannot go for massage. Would like to add upon, if there is an osteophyte also, we have to see in the X-ray where the osteophyte is. If the osteophyte is located in a place which is near to a massage, near to a muscle, then avoid massage to that area. So it all depends on case sensitive, case specific. Yeah, okay, I hope it's clear.
Ma'am, there is one more last question. Whether contrast therapy is good for osteoarthritis or not?
Yes, definitely. Contrast bath. What we do in contrast bath, we use both the cryo and also the heating heat therapy also. So initially, when you go for cryo, it causes vasoconstriction. Then when you go for thermal, it causes vasodilatation. So initially, if you are putting but again, make sure to see that you do not have an active inflammation, because we are going to use both. Right. So if you go for a cryo and the ice, it will constrict the vessels, which will decrease the blood circulation. And just after that, if you go for a mild heating, maybe a mild heating modality, then it will open up the vessels, which will help in rushing of the blood, because the vessels were constricted during ice. Now during heat, it will open up and there's a rushing of blood, and that will help you decrease spasm and washing away of your endorphins and enkephalins.
Thank you, ma'am. So with this, we have come to the end of the session. And I, Dr. Urvashi Bhattacharya, on behalf of IAPWC Kamrup branch, would like to express my gratitude towards our speaker for today for devoting so much of time and imparting such valuable knowledge. I would also like to extend my thanks to the esteemed delegates for their patience. Heartiest gratitude towards the IAP technical team for their IT support. Lastly, I would like to extend my thanks towards our national head, Dr. Ruchi Varshni, East Zone Head, Dr. Smita Singh, State Head, Dr. Pallavi Goswami, and my district colleagues, Dr. Lopa Das and Dr. Twis Lahon, without whose support today's webinar would not have been a success. Thank you, everyone.
Thank you, everyone. Thank you, IIP India. Thank you, Dr. Urvashi. Thank you to IIP Women's Cell for giving me this opportunity. I would like to look forward for any other opportunities later. And to the participants, if you have further questions, you can take my email ID from Dr. Urvashi. Feel free to mail. I'll be definitely willing to help you. Thank you all.
Thank you so much.
Thank you, everyone. I would be ending the session now. Is it okay?
Yeah, ma'am.
Thank you.